Well, good evening, everybody. It's a real pleasure. I haven't been in Little Rock in about 2 decades, and so it was really nice to have this opportunity to come here. And it's really terrific to also have the opportunity to be with Fran, the Tsarina. So she is not only does a great job here in the state of Arkansas, but people that are really familiar with a lot of the programs dealing with prescription drugs, dealing with lots of other prevention treatment issues, bringing people together from a wide array of disciplines to work on the problem. She's well known nationally. She has lectured and been asked by states that are facing many of the same problems to come up and give them a hand and to give them advice. And it's also very nice to be with my colleague, Joe Ranazizi from the Drug Enforcement Administration. Joe will have an interpreter with him tomorrow because he's from New York, and so we'll have to, but other than that, he brings a unique perspective as a lawyer, a pharmacist, and a law enforcement agent to the problem. And so we have really worked very well, as Fran said exactly, and she's so correct about this, figuring out a way to deal with this nation's drug problem, which is so significant, which causes such incredible amounts of tragedy in this country, and also costs us so much money in trying to deal with it in a smarter way. And it's also a great honor to be with Dean Rutherford and hiding in the back, okay, to be with the dean and to be here in the Clinton School. I was the deputy director of the Community-Oriented Policing Office in Washington, D.C. for Attorney General Janet Reno back in 1998. And that was, of course, President Clinton's initiative to put 100,000 cops on the street. But not just 100,000 cops, it was about community policing. It was about how to become a trusted resource and someone, police officers that were known in the neighborhoods and known in the communities. It wasn't just about trying to put how many people could you put into a city. So to be here at the Clinton School and to recognize the work that you all have done is terrific. So I'm going to make some remarks about the drug problem from the national and the international perspective, and then I think we're very interested in having more of a discussion and more of a dialogue about this. I do have a question though for the audience. If maybe someone could demonstrate Woo Pig Sooie for. You know, someone said, well, you know, you should probably do that, et cetera, but with the cameras here, I don't, you know, the president the other day had mentioned to a group of athletes that were there in the White House, and they wanted to give him some hat or helmet. He said, hey, look, you know, the first thing you learn about this job is never put anything on your head. So actually doing the Woo Pig Sooie call maybe is probably something I wouldn't want to see broadcast again and again and again and again. But maybe afterwards we can talk about it. The federal approach to drug control is one that very much understands and appreciates and recognizes what we should be doing on a state and local level. Frankly, without question, we see the states and at the local, the county, and the city level, we see them moving much more aggressively, much more assertively, in a holistic way to deal with the problem. Working with the federal government, it can be a bit difficult to get things done and to get things accomplished. And so one of the things that's most important about our office and this federal approach is that we have some incredibly talented, smart people, many that Fran has worked with. So we have brain scientists, and we have researchers, we have policy people. Our deputy director ran the substance abuse program for the state of Massachusetts. So we have this really smart, wide array of people that each year we put together the National Drug Control Strategy. The National Drug Control Strategy is the blueprint that the nation uses to look at and approach our drug problem. And essentially for the federal agencies, Health and Human Services, the Department of Justice, and others, for the federal agencies, it really does have the power of law. It tells them how they should be approaching the problem and how they should be, more importantly, spending their money. And we spend about $26 billion a year on the drug problem. And that's just that is just at the national level. No one's ever been able to get a real handle on how much we do spend in this country, because so much of it is also funded at the state and local level. When I was going through the confirmation process, someone mentioned to me during the questioning session, they said, well, you know that more people are dying of drugs than die from gunshot wounds in this country. Well, you know, I've been a police chief and been a police officer for 30, as Fran says, I got to take that out of there about that whole 37 years. And I've been a police, well, I started when I was quite young. But, you know, I've really seen, you really pay attention, as I know my colleagues do, you really pay attention to what hurts people in your community. I mean, you take this oath of office to protect people, and so you look and you see, are there robberies? Are there DUI accidents? Are there all these things that are causing harm to the people that you took this oath of office to protect? And so when they said, well, you know, more people are dying from drugs than die from gunshot wounds, I said, no, I can't believe that. And this was 4 years ago. And of course, I tested some of my colleagues and they didn't know either. And I tested some judges and I asked others. And it's driven, of course, by prescription drugs. 16,600 deaths a year due to the opioid painkillers. And when you deal with those kinds of numbers, you begin to get maybe desensitized, or it begins to blur a little bit that you're talking about human beings. You're talking about, and having traveled the country and actually having spent 4 years traveling the world, you're talking about meeting with moms and dads and brothers and sisters. I spent 4 days in Appalachia, Eastern Kentucky, in West Virginia. I spent a day with one of the senators in Southern Ohio. And you're talking about people that have been absolutely devastated, folks that have lost person after person after person, neighbors and friends, to something that we actually know we can do something about. We can prevent this, and there are things that we can do. And it isn't just the fact that now more people die from drugs than die from gunshot wounds. Now more people die from drugs than die from car crashes. If we recognize that at the level that we should, look at the amount of money, technology, education, engineering, all these things that we have put into making our roads safer, all the different systems that are in the car. Cell phones, by the way, I don't think are much of a help in road safety when it comes to when I see kids on their cell phones and texting. But when you think about all of these things that have been used to make this a safer country for the motoring public and for pedestrians, and yet more people are dying from drugs, we don't put as much time, effort, money, and research into that area. And it is something we can do something about. The economic toll is incredible. So it isn't just this loss of life. The economic toll is about $193 billion a year. That's lost productivity, that's criminal justice costs, that's healthcare costs. So when I first got the job 4 years ago and I met with the president, and he said, Gil, he said, I have a lot on my plate. Well, let me tell you, in 4 years, nothing has changed. He still has a lot on his plate. But he said, do you think we can make some progress in this area? And I said, I absolutely do. And I come from a profession that's not noted for optimism. But I said, I absolutely do. There are innovations and collaborations and partnerships going on right now that if we all had great funding and the revenues were coming in, if we all had those things, I'm not so sure we'd be so anxious to go out and figure out how to be smarter and how to deal with this problem, as Fran says, in a more holistic way or a more collaborative way. So I said, I do think we can do this, and I think that I know a lot of your priorities, but I said, I'd like you to just, keep something in mind. I don't think I said it quite that directly, but I said one of the things that when I listen to you and you talk about building a workforce and getting kids educated, a productive and safe workforce, and you talk about the healthcare initiative, and you talk about our relations, race relations in particular, and you talk about our international relations, for example, Mexico, I said you only really kind of have to scratch the surface to realize that the drug problem is right below. It doesn't always pop up as the main point of all of those things that I just mentioned, but it is always right there just below the surface. And so we've been trying to do some things about talking about the drug problem in this country. As a police chief, I've kind of considered this unexpected messenger. So as a police chief, I often talk about this issue as a public health issue and an educational issue. So it's prevention and treatment and dealing with people in recovery. And I don't think that's the message that people think about when you have a law enforcement officer talk about these things. You might expect them to say we need more people, we need better laws, we need more technology. And all those things are true to some extent. But what we really need to do is to bring a lot of other people to the forefront to deal with this problem in a way that is better. The other part was that it wasn't that many years ago that if you stood up and you talked about the drug problem from this vantage point, you would be accused of being soft on drugs or soft on crime. And that was always the third rail in the drug discussion. We passed a lot of mandatory sentencing laws. We passed a number of different laws, and we almost always turned to the criminal justice system to deal with the problem. And then we'd talk about it as a war on drugs. And the war on drugs it's a great bumper sticker, but it doesn't fit. Anybody that's the least bit familiar with the complexity of the drug problem in this country really realizes that this is not something that the criminal justice system is going to do. And frankly, for all my colleagues, I never actually heard them talk about the war on drugs. What they often did say, though, is that we can't arrest our way out of this drug problem. And so when I told a reporter that, the reporter being suspicious, said, well, you know, let me call some police chiefs around the country just to see, because I'm not so sure they'll agree with you that this approach might make more sense. And so he called about 6 police chiefs in the Chicago area. All 6 said, no, he's exactly right. This is an approach that can be smarter on drugs and, frankly, smarter on crime. So we have this comprehensive and responsive plan to treat addiction as a public health problem, to recognize it as a brain disease, and to not just kind of think about it as, well, gee, why don't they just stop using drugs? Why don't they find God? Why don't they pull themselves up by their bootstraps, et cetera, et cetera? When you recognize it as a disease that can be diagnosed, a chronic disease that can also be treated, it makes a huge difference in the way you approach the problem. And we certainly try to put that in perspective. The other important part of the perspective is we recognize how important it is when we produce the National Drug Control Strategy that it has the voices of the American people in it. So the President's direction to me was, look, I really want the voices of the American people. And so we spent about 4 or 5 months traveling the country. We talked to, or actually we more listened to police chiefs and sheriffs and prosecutors. We listened to judges and drug court judges. We listened to a whole host of people that run treatment programs, prevention programs, and then we talked to people that are in treatment, people in rehab, and we talked to people that are in recovery. And of course, we know there are over 20 million Americans in recovery from substance use disorders. The other difficulty that we have is that it is so hard to get people to focus on spending money on prevention. Prevention makes so much sense. And as a police chief, no one ever gave me credit for crimes we prevented. No one ever said, boy, that was terrific. If something happened, how fast did you get to the scene? Did you make an arrest? Did you get my property back? But then if you'd asked that victim of that crime, wouldn't it have been better if the crime had not have happened at all? Well, of course, we all know what the answer to that is. And that's about drug prevention. We know that prevention can work. We know that community-based, school-based, evidence-based programs can make a huge difference. That's why in our office we help to fund with our partners at the Substance Abuse and Mental Health Services Administration, we fund about 700 drug-free communities. Small grants, and by the way, there are 5 right in this area, small grants that kind of sustain people, that they have to work together. They have to have a sign-off from the school school system and the law enforcement authorities and others. And these neighborhood-based groups can deliver an evidence-based message about prevention that makes an awful lot of sense. And we know it's effective, we know it works, but it is so hard to get people to loosen up the purse strings when it comes to paying for prevention, even though we know in the long run that's the best way to deal with it. We know that the medical community is on the front line of the drug use prevention. That's why we've worked very hard with them to do several programs. One is called ESPERT. You know, I'm from the federal government, so we have to have an acronym for every. I'll give you a few other acronyms later that we can use and throw out and impress your friends. ESPERT is really, it's called Screening, Brief Intervention, Referral to Treatment. And even though there's a lot of science behind it, here's what it is in a nutshell. Most people see a healthcare professional about once a year, a doctor, a physician's assistant, etc. And at the time, well, if you're out here in the sun a lot and you go in and you say, I'd like you to take a look at this mole, and the doctor or the physician's assistant, etc., the healthcare professional says, oh, and let me ask you about substance use. Let me ask you about your alcohol use, and let me ask you about your about drugs. Most people are very honest with their healthcare professional, and they will give them information. And that intervention can be very early, and it can be, well, I think you need to take a look at that issue also. Or it can even lead to where they recommend something further down the road. Because we know that if an intervention occurs early, it's often more successful, and it's certainly usually less expensive. We know that drug treatment works. It's very frustrating to hear, you know, well, I know people that have been in rehab half a dozen times. Well, look, we all know that President Clinton had a statin that he took. And for a while, when he was feeling better and his cholesterol levels were better, he wasn't taking that statin, and we know he had a reaction to that. So the drug treatment is this ongoing treatment program. It isn't, you know, it isn't like you go in with a broken arm and, you know, you get the x-ray and then you get the cast off and it looks like it's healed and you're fixed. You know, treating somebody with an addiction problem in the long term is still far less expensive than incarceration. But we shouldn't recognize it as this magic miracle that suddenly somebody went in for 28 days of inpatient in treatment and now they're going to be just fine. We need to recognize it for the complexity, and we also need to recognize it in a way that makes an awful lot of sense. And the Clinton Global Initiative, I'm particularly proud of. They have taken on the prescription drug issue and have held a number of meetings, and when President Clinton takes on an issue, and he can certainly bring far more attention to it than I can, and they have. And it was after the loss of one of their young staff members to a prescription drug overdose that they recognized and realized it, and so I really applaud them for taking this issue on. The CDC in Atlanta has called prescription drugs, our prescription drug addiction, our problem, an epidemic. And Dr. Frieden, who's head of the CDC, doesn't use the term epidemic in a light manner. It is a very well-defined term. And so when they call it an epidemic, we know that it is quite serious. But we also know we can really do something about it. We also know that emergency department visits have been up. So it's not this tragedy of the loss of life, it's also the number of people being admitted into an emergency department. And we know, and of course the doctor knows, you know, how busy some of these EDs are. And just think if you could cut down the number of people coming in as a result of a drug problem, how much better that would be for healthcare, and in a whole host of ways. You know, the prescription drug problem is the great equalizer in this country. It cuts across every demographic, every economic issue, and from young to old. And of course, there was a recent long, lengthy article in the Wall Street Journal the other day about the number of women that are now dying of prescription drug overdoses. But we know there are things we can do about it. And so we tried to be smart about it and put together everybody that was a stakeholder in prescription drugs. And we came up with a whole host of things that we think are beginning to make a difference. So prescribers, doctors, pharmacists, and others need to be educated about prescription drugs. Oftentimes we know that in med school or pharmacy school there's not, well more so in pharmacy school, but in med school there's not a lot of discussion about drugs, that these can be addictive, that about tolerance, about dependence, etc. There's not a lot of that, and so we're really trying to push in a whole host of ways prescriber education. But then there's a whole nother group that we have to educate, and that's young people. And young people go into their mom or dad's medicine cabinet, or they go into their neighbor's medicine cabinet, or they go into grandmother or grandfather's medicine cabinet, and they think, well, let's try something from here. It can't be that harmful because, after all, it's in a prescription bottle. It came from a doctor. I'm not buying it from behind a convenience store in a piece of tinfoil or a piece of cellophane. So they think it's safe, and of course it's not. These opioid painkillers are just as deadly and just as addictive as heroin, and we know that. So the education part has been particularly important. We know that prescription drug monitoring programs, which every state but the state of Missouri has one, can be used by physicians and boards of licensure to see if somebody's doctor shopping. Or the licensing board can see if perhaps a physician is writing an awful lot of prescriptions and there needs to be a more refined look at that individual. And the PDMPs are state-based, they're not a national base at all. It's a state-based system, and they can be really helpful. The other thing that we can do is certainly around cleaning out medicine cabinets. There's been no greater partner in this country than what the Drug Enforcement Administration and now well over 5,000 local law enforcement agencies do when they do these drug take-back days. And I don't think there's a better drug take-back program than here in Arkansas. So cleaning out those medicine cabinets and getting rid of those drugs in a safe manner, in an environmentally conscious manner, makes a lot of sense. And then the last thing, of course, is the enforcement side. So the Drug Enforcement Administration, again with their state and local partners, have about 50 tactical diversion squads in existence around the country. And these are the squads that go after doctors who may be violating the law. They go after others that where the diversion is happening and the drugs are getting into the system in an illegal method, and that has to be done. And they can make a huge difference. You just look back at Florida a couple years ago in the Broward County area. 90 of the 100 top prescribing and dispensing physicians had their practice in Florida for these drugs. And you look at the chart on prescriptions for opioids, every state, including California, is kind of like this and up and down. And you go to Florida, and it is just, it was through the ceiling. 7 deaths a day in that state due to prescription drugs. But all of these people working together, an aggressive Attorney General and Pam Bondi, a really good collaboration with the DEA and law enforcement, and the next thing you know, a number of those doctors have left, and now it's down to just a handful that are there. And then, of course, working with the pharmaceutical companies. Because these drugs can be easily manipulated to be used in a syringe or snorted, the drug companies are able to develop abuse-resistant formulas where that can't be done. So we think all of these things coming together, this federal government broader approach, is a help to the states. And we're seeing, again, as I said, we're seeing a lot more going on in the states than at times at the federal level. And that's why we're so interested in being a part of the reform of criminal justice. In my long career in criminal justice, I don't think there is anything moving more quickly, whether it's in a conservative state or a state that is governed by more progressives. Regardless of the partisan stripe, there is a lot going on. Governors are saying, look, we got to reduce our incarceration rate, we have to save money, but we also want to take that money and put it back into a system that provides aftercare, that provides support, that gets people back being part of their community. And as interesting as this job has been, there's been nothing better than to travel around the country and meet people who are in recovery. And I've had friends, longtime police chiefs that I never realized, and they'd say afterwards, well, you know, I've been in recovery 30 years. Or I've been people that you just never, a chief prosecuting attorney, et cetera. And when you realize that you can take away some of the stigma and help people talk about this issue in a more open way, I think that also makes a huge difference. So we're doing a lot, but we could be doing more, and that's why we have this great opportunity not only to come here and visit with you, but also this opportunity tomorrow to be with about 700 people who have a really deep and abiding interest in the drug problem, particularly the focus tomorrow on prescription drugs. So with that, I think I've spoken by far long enough, and we have some time for questions and discussions. And am I the moderator? Am I mediating, or am I? Well, that's all right. I can moderate pretty well. So whatever questions or discussion, it does. You know, I'm happy to. We've got people with a microphone, so you can make sure you're on candid camera later. But we're happy to talk about these things. So please. All right. Don't all start at once. Questions, comments? Sure, yes, ma'am.
I'm going to stand up because I'm short. But I am one of those drug-free community grantees from Union County. And my question is, are we getting closer perhaps to being able to put the prescription drug take-back boxes at, say, pharmacies at that point where they pick them up? We have as many boxes in our county as we can, 4 of them, because those are the only 4 policeman stations that we have. But our law enforcement would be happy to go and pick them up at pharmacies as well. So that's my question. And
I actually, I'll answer a little bit for this. You know that it was against the law in the past for a pharmacy or a doctor to actually take drugs back. They could dispense, but they couldn't accept them back. And the law had to be changed. And as you might guess, there hasn't been a lot of bipartisanship in Washington, D.C. lately. But this was an area that was bipartisan. And the law was changed, and it allowed the Drug Enforcement Administration to write new rules to make it easier. So the drug take-back with law enforcement is terrific. But you know, there are a lot of law enforcement agencies that aren't always able to do it. They've only got a couple of officers. Most agencies are pretty small. And so it becomes pretty difficult. So the new rules have been written and were out for comment and are in the process now. And I think the outcome, you'll be pretty satisfied with an array of ways that some of these drugs, whether it's a rural area or a town or a village, can be disposed of safely and not filter back into the system, which is something that everybody is always concerned about. So I can't give you an exact timeline, but I think we're pretty close. Did that sound good, Joe? Okay, good, thanks. Other questions or comments on the drug issues? Nobody wants to talk about marijuana? I mean, really, please, yes, ma'am.
Coming up with the microphone. 1 second.
Is there any sort of contact between your agency, legalization of marijuana and so on? Does this affect all? Then if that is readily available, that will be a prescription drug. What is your comment, or are you allowed to?
Oh, no, I actually, when I first got the job and I did that interview and I said, look, we got to quit calling this a war on drugs. And that was the first week I was there. And some young person in the White House communications called and said, oh gosh, are you sure you really want to say that? You know, don't you want to be seen as being tough on drugs? And I said, you know, I've spent 37 years kind of being tough on this issue. Why don't we be smart on this issue? And I thought, you know, if this doesn't go well, I'll be a consultant. But so far, you know, they haven't fired me over this. So I'll tell you a little bit on the marijuana issue. So 18 states have medical marijuana. Remember that marijuana has never been through the world-renowned FDA process. So there's no drug that doesn't go through the FDA process, but marijuana has never been through it. These are individual state laws, and they have been around going back to 1996 in California. And when I became police chief in Seattle in 2000, the law had just passed before that. Frankly, it was a pretty non-issue until these last 5 or 6 years. And on the medical marijuana issue, it has just kind of exploded. And so what started out as people wanting to use marijuana because of going through chemotherapy and the nausea, or I think glaucoma at times, or muscle spasticity as a result of MS, what it's now become is, and the research is pretty clear on this, is that the people that hold medical marijuana cards are 30-year-old white males. I don't know about you, but that's not the sickest group of people in this country, unless you believe that we have a lot of very sickly 30-year-old white males. So the medical marijuana issue is going kind of state by state by state. 2 states, though, Washington and Colorado, passed through the initiative process or proposition process, recreational use of marijuana to be regulated and controlled. A lot of money, a lot of outside money was spent in both of those states for very, very slick ads. And it had been in front of the California voters 2 years earlier, before that election. And you would listen to the commentary, and you would think that this is going to save the world. It's going to reduce violence in Mexico. It's going to allow the police who've been chasing kids around to go back to investigating murders because they hadn't been doing that. It was just really, that you could tax it and regulate it. But we know a lot, and we know that when you do the research and you look into it a little more deeply than a very slick television ad in Washington or Colorado, that none of this holds true. None of this holds up to the scrutiny that it won't reduce violence in Mexico, that for every $1 in alcohol taxes we collect, we spend about $8. That's $8 coming out of your pocket for criminal justice and social and health care costs. So we can't begin to collect enough in alcohol for the damage it does. Are we really so certain that we'll be able to collect enough taxes in marijuana? And then there are all these discussions around prohibition, et cetera. You know, the president has made a number of statements opposing legalization of marijuana. From our perspective, we look at it from that healthcare perspective quite often. It's not a benign substance. It's much more powerful. It's much more potent than the marijuana that some people in this room might have remembered from an earlier time. There are significant health effects around it, and we shouldn't be rushing to make this more widely accessible and available. So I think we're going to be in for a bit of a difficult time. But I think the more people that recognize the concerns, the legitimate concerns that have been expressed, the better. So we'll see. Other questions or comments? Yes, please.
We'll just stay at this table for a while.
That's an active table.
Yeah.
Well, you mentioned Washington State, and I know that Washington State had enacted laws about prescription opioids. Can you tell us what you see as the difference that has made in that state, in deaths in the state, in the amount of opioids prescribed?
Yeah, Washington State was unique in that there was a drug treatment professional from the Vancouver area of Washington that got elected to the legislature. And he pretty clearly recognized what was going on. And he put forward a series of laws that were passed before there was time for a lot of opposition to be raised about it. Some of these laws seem to be making an impact. The numbers from Washington State look a lot better when it comes to the fact that you can only prescribe as a physician so long before the person has to go see an addiction specialist, a doctor really trained in that particular area. There are kind of a number of other provisions, so those laws have kind of put it on the map. And most of what I've read has been pretty successful so far in Washington State. But we're also kind of seeing, by the way, finally now, a bit of a downturn in prescriptions. Young people are more aware of the dangers and the problems of prescription drugs. So I'm pretty optimistic that nationwide we'll be seeing better outcomes when it comes to prescription drugs. I tested it myself. I had a root canal a couple months ago, and you know, the dentists were the #1 prescriber. I mean, so here you are, 17 as a kid, and you're having your wisdom teeth taken out, and you get 30 or 60 or 90 Oxycontin, which was, you know, a large number of pills. And one of the doctors at the FDA, her daughter came home and said, "Mom, do you know how much we could sell these for if they go for in high school?" And her mother said, "Oh." So when I had my root canal, the doctor prescribed ibuprofen. So then I had to tell him what I did, and I had to ask him. I said, you know, ibuprofen? He said, yeah. He said, it's better for pain. It reduces swelling. And he said, and if you're in more pain, he said, you have my number. That's why you paid me to do this. You should call me. Too often what we've been seeing is, look, if you give somebody 30 days worth or 30 pills, you know, they're not going to be calling the doctor's office needing a prescription. And that's probably not the right approach. We need to be a little more cautious about it. So some things are going on that are pretty helpful as a result of this. Other questions? Yes, sir.
It's coming behind you.
Sure.
You were talking about the federal government's study on marijuana. I believe that back in the 80s, there was a lengthy study done right here in Arkansas by the FDA down at the National Center for Toxicological Research, about 40 or 50 miles southeast of here down in Jefferson, Arkansas. And you might check the results of that, but from what I understand, it was, you know, pretty much determined after all their studies that it was, you know, fairly benign. Now, last November, Arkansas had a medical marijuana act that was done as a ballot initiative by the citizens, and it came very close to passing. Several weeks before the election, the Pharmacy Association came out in opposition because of the fact that as long as marijuana, medical or otherwise, is classified as a Class 1 narcotic drug, it is legal under the federal government. And even if it were to be legalized here in Arkansas for medical purposes, it could not be dispensed through a licensed pharmacy because it was illegal. It would be illegal for them to dispense it. Right. What are the chances of taking medical marijuana out of that Class 1 narcotic that would allow the pharmaceutical industry to grow and process it where it could be sold for the, you know, disease that it has been shown to be effective on, and at least treatment of the side effects of chemotherapy and stuff? So if it were just removed from the Class 1 classification.
And it's, yeah, the Schedule 1 means that a drug has no medical efficacy, no legitimate medical purpose, and that's where marijuana is. But so there are a couple of things that are important. One is that back when the medical marijuana issue in California in '95, et cetera, because of the chemotherapy, the drugs that are in place now, the other drugs that are in place to deal with the effects of chemo and on, and the way chemo is administered, there are huge, significant changes in the way this is done. You know, in eating a marijuana brownie or inhaling smoke, you know, into your lungs may not be, you know, the best thing anymore. Those things have changed. So on the market is Marinol, on the market is Sesame, and coming to the market is Sativex. These are all derivatives of marijuana that have gone through the FDA process. Sativex is in use in Canada and Europe, I believe. These are all things that have gone through the process. The difficulty is with this is the fact is they're not very popular because they don't get you high. The stuff that's in marijuana to get you high isn't a part of these medical properties. So I think the other part is around scheduling. Because it's a Schedule 1, people say, well, then no research can be done on what really benefits marijuana may actually have in the healthcare field. Actually, there are about 200 researchers that have DEA licenses to research marijuana. There are about 29 active research programs going on. But here's kind of the kicker around all this, is that the pharmaceutical industry says it takes a little over $1 billion to take a drug from development to the marketplace, $1 billion. And if you're going to invest $1 billion, I mean, you want Lipitor. You want something that is going to make you a lot of money. Marijuana isn't going to make any pharmaceutical company a lot of money, and therefore there's no big interest in taking a look at it. That's why, these other 3 chemicals that I just mentioned, or these other 3 derivatives that are on the market, are available. They're just not very popular. So removing it from Schedule 1 wouldn't mean, and it's done through a process that involves scientists. The times they've looked at it, they haven't seen any changes. Probably isn't going to be, isn't going to be the magic answer to whether marijuana has additional properties, but that may be effective. And the research should continue. People should continue to do research on it. Other questions? Yes, sir.
This in front of you first,
sure.
and then we'll go back. Yeah, you have the microphone first, and then we'll go back.
Sure.
You mentioned the crackdown in Florida that was going on, and I know the DEA has been going to pharmacies that are dispensing large volumes of hydrocodone and making sure that there's a legitimate prescription there. And so the pharmacies have been calling the physician to verify the prescriptions, and the physician's offices have been inundated with phone calls. And in fact, the AMA came out and said they had a policy statement in their House of Delegates that said they didn't want pharmacists calling and interfering with their practice of medicine. And so, which I think is a poor statement, but how can we get these pharmacists, physicians working together to try to curb this problem without having the DEA and the regulatory bodies breathing down your throat?
Well, I think that, a couple of things that I think are really helpful, and certainly tomorrow when Fran brings together 700 people, including doctors and pharmacists and others, it oftentimes leads to further collaboration or discussion. But one interesting part, and Joe is a pharmacist, and I'm sure will tell you tomorrow, that pharmacists have a lawful, legal, and ethical requirement to verify and to check a prescription. It isn't just that, well, I've got the script and now I'm going to fill it exactly this way. And in fact, they have a requirement that they can refuse to fill the prescription. So, sometimes I think people don't realize the important part, but when you look at your neighbors and friends and you sometimes see who they get medical advice from, oftentimes it's going into the drugstore and talking to the pharmacist behind the counter. So I think sometimes we don't give them as much attention and recognize the authority and the responsibility that pharmacists have to actually do that. So I think I think the prescription drug monitoring program, which has only been up for a couple of months here, that electronic database in the future really has the power to cut down on some of those phone calls to the doctor's office. So we'll see. Hey.
Hi. Some countries have experimented with decriminalization as a way to reduce the use of drugs, both illegal and prescription. A good example is Portugal, which has seen remarkable decreases in drug usage, both prescription and illegal drugs. So what is your opinion on a decriminalization?
Well, the Cato Institute did this glowing report about Portugal that this is the answer to the drug problem, and they had a significant HIV and overdose drug issue. And so I spent a few days in Portugal with a number of people that were involved in the program. So a couple of things. One is, as all of the people that I met with, whether they were in government or whether they were part of the programs, et cetera, were the first to say that, look, this isn't the silver bullet or the miracle. And in fact, the HIV infection rate in Portugal is actually higher than in the EU level. But the decriminalization part has been interesting. I mean, we're seeing across the country, states and local entities decriminalizing marijuana. That's not legalizing marijuana, it's decriminalizing it, saying that possession of a small amount of marijuana by an adult is not a criminal violation. It can be a fine, a sanction, a citation, that type of thing. Because treatment, going in front of a group of people because you possess drugs in Portugal, they make an assessment whether you should go into treatment or not. That isn't terrifically dissimilar from places around the United States. You just also have to put in perspective that Portugal's a country, as they told me, look, we're a country of 10 million, mostly Catholics. We're not sure that what we do here translates particularly well to a diverse nation the size of the United States. But I think there were some things worth looking at. The Netherlands, on the other hand, which was always held up to be this place with the marijuana cafes, they pretty much ended their 30-year love affair with marijuana. They began shutting down literally hundreds of cafes, except those in Amsterdam. They have required that you show your identification from the Netherlands if you're in a marijuana cafe and buying marijuana, because they were tired of the drug tourists coming in. And they're also taking the higher potency marijuana and now classifying it at the level of cocaine because they recognize that it's different. So I think we kind of should learn and be open to what we see in other countries, but I think we also need to realize, just like war on drugs isn't an answer and neither is legalization, it's a lot more complex than that. Good question, though.
We have time for one more.
One more question. You could win the prize, Doctor.
I do need to start giving out prizes. One second. Just wait, just so that everyone can hear you.
What's the status of changing hydrocodone from Schedule 3 to Schedule 2?
There are, the hearings have been held. The advisory panel to the FDA, and it is an advisory panel, a majority voted in favor of changing it, making it to a higher level. But the FDA has not made a decision on it, and I think it will be a little while longer before they do. The number of comments that came in to them were quite a few. But I think the recognition that the advisory panel, was it like 17 to 12, Joe? 19 to 10. Voted in favor of moving hydrocodone up to a higher level, which would then, of course, cause certain requirements and refills, right, and prescription practices that may be helpful. Just remember, there's, I should, this, but for others, there's lots of other drugs that we need to be, also very concerned about, and but hydrocodone, taking that to a different level, is something being considered. Thank you very much for the time and coming out tonight.